All right, so we'll go ahead and get started and then let everyone continue to join. So good evening, everyone. Today it is my honor to introduce Dr. Linda Liau, who really needs no introduction, but I'm thrilled to recount her many accomplishments for the group anyways. Dr. Liau is currently professor and chair of the Department of Neurosurgery at the David Geffen School of Medicine at UCLA, where she is the co-director of the Brain Tumor Center, PI and director of the NCI-designated brain tumor SPORE as well. She's had a truly remarkable career, starting with her undergraduate studies in biochemistry and political science at Brown, where, as a fun fact, she was named by Time Magazine as one of the top 100 college students in the United States, which I didn't even know that list existed, but that's wonderful. She then ventured to warmer climates, receiving her MD at Stanford and a PhD in neuroscience at UCLA. Dr. Liau then completed her neurosurgical residency and a fellowship in neurosurgical oncology at UCLA, after which she joined the faculty with a rapid acceleration in her clinical and research pursuits. She's had continuous NIH funding for her work over the past 25 years, which focuses on translational immunotherapies for brain tumors and biomarkers. She's very well known for pioneering dendritic cell-based vaccines for glioblastoma and has really helped to launch the investigation of immune-based therapies for glioma in our field. In a real testament to her contributions to science, she was elected to the National Academy of Medicine in 2018, and her work has resulted in over 200 peer-reviewed papers, chapters, and a foundational textbook. She's on innumerable scientific committees and boards, leading our field both nationally and internationally. She served as editor-in-chief of the Journal of Neuro-Oncology from 2007 to 2018, also serving first as board director of the American Board of Neurological Surgery, and then becoming its first woman chair from 2019 to 2020. During this time, because of course she was not busy enough, she also received an MBA from UCLA, going on to become a tenured professor of neurosurgery in 2007 and chair of the department in 2017. She has mentored dozens of medical students, residents, postdocs, and junior faculty, really leaving an indelible impression on the next generation. Dr. Liau represents the rare triple threat in our field and has further been a real trailblazer for women in neurosurgery and neuro-oncology. Dr. Liau, we are just so delighted to have you here today.
Well, thank you so much for that very kind introduction, Rupa, and thank you so much for having me. It's really nice to kind of see kind of some of my old friends, at least on the Zoom name screen, and it's really a pleasure to be here. Today I'm gonna talk about targeting immunotherapy-induced resistance in glioblastoma. And what's a little bit different about this is, we've talked a lot about, resistance to treatments, and there's certainly resistance mechanisms to immunotherapy. But now we're learning that there's actually resistance that occurs from our therapies. Basically, our therapies are causing these tumors to create even further resistance to treatments. And when I started in this field, almost 30 years ago, I thought we would have a cure to GBM by now, but unfortunately we don't. And I think the complexities of this disease are just, getting to be better elucidated. So I'm gonna just, let's see if I can move forward. So, these are my disclosures. And then, so just as an introduction, in terms of FDA-approved treatments for glioblastoma, as we all know, radiation and chemotherapy is still the standard of care for this treatment. Radiation's been around since the mid-70s, and really nothing happened for about 20 years. The only treatment available to our patients was radiation and surgery. BCNU and CCNU was FDA approved at the time, but the clinical trials really didn't show any added efficacy over radiation. So for about 20 years or so, radiation was the treatment. Actually, for about 25 to 30 years, that was kind of the mainstay of treatment. In the late 90s, then the gliadel wafer was approved, and as was temozolomide. And then in 2005, with the Stoop protocol, the standard of care for glioblastomas, it became radiation with concomitant temozolomide. And really, that's kind of been the standard of care for the last 15 years. And there have been a few other things that have been FDA approved, Bevacizumab for recurrent GBMs, and then the tumor treating fields, the Optune device. But other than that, really nothing has been FDA approved for many decades for this disease. And that's not for lack of trying. And as a a comparison, in the last 5 years, there have been over 50 cancer immunotherapy drugs approved for glioblastoma, none yet for other cancers, but none yet for glioblastoma, none yet for brain cancer. And these are all the different cancers where there are now immunotherapeutic drugs that are available for patients, even pancreatic cancer. I mean, in some small subsets of pancreatic cancer, there are some drugs that are FDA approved for these very small subsets of patients. So what is making glioblastoma so difficult to treat, particularly with standard treatments, but also with immunotherapy? And again, it isn't for lack of trying. As you know, many checkpoint inhibitors have been FDA approved for other cancers, and there have been several large clinical trials of checkpoint inhibition for glioblastoma, and this is one of the the initial ones, Nivolumab versus Bevacizumab in patients with recurrent glioblastoma, and as you can see, the two survival curves are essentially the same, and this was published in just a little over a year ago, and in I guess true form, we always hear about these trials from the pharma companies, oftentimes before they actually get published. So that trial that was published in JAMA Oncology was Checkmate 143. That was just Nivolumab alone, and then there's also been Checkmate 498. That's Nivolumab with radiation, and then Nivolumab with Ipilimumab, and these are still these are trials that, unfortunately have not reached their primary endpoints, but there are now, different combinations of these types of checkpoint inhibitors with other treatments. So, and for a while, it's thought that perhaps, immunotherapy, at least checkpoint inhibition wasn't a viable treatment for glioblastoma. But then, a couple years ago, this paper from our group at UCLA, as well as Patrick Wynn at the Brigham, as well as some other groups that have kind of published similar studies, showed that perhaps it's the timing of these treatments. So this is a paper that showed that if you gave anti-PD-1 inhibition neoadjuvantly, meaning before surgery, there was some increase in survival in these recurrent glioblastoma patients. And granted, the numbers are very small. We're talking only about 16 patients versus 19 patients in the other arm. It was a statistically significant difference. And interestingly, this was one of those window of opportunity studies. So we actually took the patient's tumor samples after the administration of neoadjuvant anti-PD-1 inhibitors, and then looked at immune signatures, and there was an increase in gamma interferon signatures in the neoadjuvant group versus those who did not get neoadjuvant pembrolizumab, suggesting that an upregulation of the interferon gamma pathway may play a role in this. But at around the same time, there were other studies that came out that suggested that if you give PD-1 blockade in a subprimed setting, basically the T cells are not yet primed against your antigen, you could actually induce dysfunctional PD-1 positive cells and anti-PD-1 resistance. So actually, its count, basically makes the tumor more resistant to immunotherapy if you actually give a checkpoint inhibitor without activating the T cells. And that's always been a problem with glioblastomas. It's actually an immunologically cold tumor for the most part. You're not, many studies have shown that although there are some T cells in glioblastoma, there aren't very many. And perhaps the results that we're seeing with neoadjuvant treatment of these tumors is that for those patients that have T cells in the tumor, you are perhaps able to induce activation or of those T cells against the antigen. However, this would suggest that if you have a subprimed T cell, the use of a checkpoint inhibitor may actually make your tumor even more immune resistant. And in some work done by Rob Prinz in our group at UCLA, what he found was that in glioblastoma patients, the expression of PD-1 by T cells in these tumor samples actually reflect exhausted T cells. And this is just a study looking at different markers of T cells. They're the activated T cells, they're the memory T cells, the activation T cells, and the exhaustion T cells. And in glioblastoma patients, both in the, mostly in the tumor infiltrating cells, most of those cells are exhausted or in that path to exhaustion. So the question is, well, how do we perhaps revive those T cells so that they can be tumor specific and actually attack these tumors and really drive this to the memory T cells, which is actually what we want. Patients do have memory T cells in the periphery, but these T cells are just not getting into the tumors when they're infiltrating into the tumors. To that regard, we went back and looked at basically the tumor samples from the patients that were enrolled in the neoadjuvant PD-1 blockade trial and looked at their tumor infiltrating T cells and kind of to see, well, what was found was that these patients perhaps had an increased survival. There was an increased interferon gamma signature in these tumor samples. And then the next question was, well, what's going on with those T cells? So from the resected tumor tissue, we isolated the CD45 cells and then did CyTOF mass spectroscopy or single cell genomic sequencing. And most of this work was done by Rob Prinz and his group along with the people working in our labs collectively. And this actually was part of our SPORE project as part of our UCLA brain cancer SPORE. But what we found was that the neoadjuvant anti-PD-1 treatment, it did increase perhaps the number of T cells, but these T cells were actually progenitor-like exhausted T cells. They actually had exhausted T cell markers. For instance, in this cluster, this L4 cluster here, as well as there was an increase in Treg cells, which are also immunosuppressive T cells. So I guess as a feedback mechanism that these tumors kind of probably were expressing was that when we treated with these anti-PD-1 inhibitors, it actually drove these T cells further to exhaustion. And that could be one mechanism for resistance, because if you have T cells that you have a small number of T cells in the tumor, perhaps you are increasing the activation of those T cells, but then you're actually overstimulating them to a point of exhaustion that they can't really attack the tumors. But actually the bigger immunosuppressive effect of anti-PD-1 therapy or immunotherapy prior to T cell activation is this infiltration of immunosuppressive macrophages and myeloid cells. So what we found was that anti-PD-1 treatment in a population of patients induces upregulation of immunosuppressive macrophages and myeloid cells. So even though you're getting more T cells in, and perhaps the T cells are more activated, so, the T cells may be getting exhausted. And then on top of that, you're recruiting this whole population of immunosuppressive cells that are actually coming in to fight the T cells. So there's really this kind of battle going on in the tumor microenvironment that is actually induced by our treatments. And so I think in order to really get effective treatments for glioblastoma, we really need to understand what our treatments actually cause and the timeline for that. You know, when the tumor, you know, when certain treatments should be given to mitigate some of these immunosuppressive responses. So how do you get more T cells into the tumor? So, because that's really, and I still believe that is the first step. The problem with, and probably one of the reasons that immune checkpoint inhibitors don't work as a single agent for glioblastoma is that we don't really have a lot of T cells in the tumor. And even if they're in there, they're exhausted. So we really need to recruit new T cells from the periphery because as I showed in the in this slide here, oops, the glioblastoma patients do have memory T cells and activated T cells in the periphery, but how do we get them into the tumor? One of the best ways to actually get T cells into the tumor is through active vaccination. And this was actually work that I did as part of my my first KOA award many years ago. And what we were the first group to find that with vaccination we could actually get T cells to cross the blood-brain barrier and go into brain tumors. I didn't realize that at the time, but apparently no one else had found this before this point. And it was because at the time it was thought that the brain was immune privileged, so that there was no way to get activated T cells, or at least tumor specific T cells, to migrate from the periphery into brain tumors, or at least it's thought that that doesn't happen. Now, of course, people know that it does, and it actually happens in several different pathologies besides brain tumors as well. But now, now I think we understand that there are ways to get T cells into tumors, either by active vaccination. Sometimes we, oncolytic viruses do that, as well as, you could actually just give adoptive therapy of CAR T cells or other types of T cells directly into the tumor. But the first step needs to be getting those kind of fresh, non-exhausted T cells into the tumor. And then once, those initial studies that we did using dendritic cell vaccination, for instance, did show that T cells got into the tumor, and then we did see some increased survival in patients in the early trials, particularly in patients with the mesenchymal subtype of glioblastoma. And these studies subsequently led to other phase 1, phase 2, and phase 3 clinical trials, which I'm not going to talk about in this talk. But what I wanted to focus on were the resistance mechanisms that we learned from all these studies over the years. So as I mentioned, this was a paper we published 10 years ago. What we found was that when we used dendritic cell vaccination, the mesenchymal gene expression signature was associated with the increased tumor infiltrating lymphocytes. And we often see this in increased contrast enhancement after treatment, which subsequently went away on its own. And in these patients, when we were able to get the post-treatment specimens, we saw this kind of large infiltration of CD8 T cells, which wasn't visible, or we didn't see in, for instance, the pro-neural subgroup of glioblastoma patients. So this mesenchymal subtype tends to be more immunoresponsive. It tends to react more to immunotherapy in the sense that you could get T cells into these tumors. So we then went to look at, well, what kind of, what can we do to make glioblastomas more immune responsive to help turn these kind of relatively cold tumors to more hot tumors. And some adjuvants that could be used are things like toll-like receptors. TLRs recognize PAMPs, pathogen-associated molecular patterns, and it's really an important element in the innate immune system. And there happened to be, for instance, FDA-approved TL7 agonists. There's a drug called Imicumod and Risicumod that's been FDA-approved for warts. And then TL3 agonists, there's a drug called poly-ICC that's been used in the past for glioblastoma in clinical trials. It actually was negative as a single agent, but I think in combination with vaccination or with some sort of T cell activation signal, these TLR agonists could be of benefit. So we did a small clinical trial to test that. We looked at a group of patients who just got all these patients got DC vaccination. So we looked at a group that got DC vaccination plus placebo, DC vaccination plus poly-ICC, which is a TLR-3 agonist, or DC vaccination plus imicumod. And what we found was that with the TLR agonist, the poly-ICC, there was an increased effector PD-1 positive T cell response. So, and there was also an increase, number and activation of CD8 T cells, suggesting that this particular adjuvant was driving these cells more towards activation and less towards the immunosuppressive phenotype. And we also looked at this with single cell sequencing, again, looking at the T cell cluster, showing, a drive of these T cells to active memory T cells, as opposed to the more kind of naive anergic T cells. And we did gene expression profiling and showed that this particular group that got treated with the poly-ICC, actually both the groups that got treated with poly-ICC as well as Risicumod did show some changes in myeloid cell differentiation gene expression patterns, as well as lymphocyte gene expression patterns, more so in the poly-ICC group than the Risicumod group. And these adjuvants really help to elicit a very strong type 1, type 2 interferon response. And then what was even more interesting was that with poly-ICC, actually the patients live longer. This particular group, albeit the numbers are very small, but it was statistically significant. The group that got dendritic cell vaccination plus poly-ICC had a 50% survival rate, and now we're the majority of these patients are reaching 100 months, and with not only survival but really no tumor recurrence. So it does suggest that there is some added benefit to adding these adjuvants to T cell activation signals. And as I mentioned, I think one reason that single agent checkpoint inhibitors aren't working in glioblastoma is because the T cells are not getting in. And what we do know is that at least in our animal studies and several other studies, is that you do need an activation signal to get the peripheral T cells to go into the brain tumors. Sometimes we already see glioblastomas with T cells, so there probably was some activation signal that got those cells in there. But for the most part, the majority of these tumors don't really express a lot of activated T cells. But the dendritic cell vaccination is able to get these T cells infiltrated into the tumor. And these are just schematics of what happens. If you just use the anti-PD-1 antibody alone, we don't really see a significant increase in T cells in the tumor. If you use the dendritic cell vaccination, we do see increased T cells into the tumor. But in terms of if we combine the two, then we see not only an increase in numbers, but also the increase in perhaps percentage of activation signals inactivated T cells. So the thought is that, again, PD-1 blockade alone did not show a response in our animal models. If we gave dendritic cell vaccination alone, we did see a response to some of the animals, but it was not in all of the animals. And part of that was because the percent of T cells that were activated was relatively low compared to when we actually used both agents alone. However, what we also found was that when we used dendritic cell vaccination plus PD-1 inhibition, again, you get more T cells into the tumor, but then you also get a compensatory migration of these immune suppressive cells that are actually coming in from the periphery to try to basically suppress that immune response that is being activated by the activated T cells plus checkpoint inhibition. So our initial clinical trial that we started as part of our SPORE 5 years ago was to look at basically the effect of neoadjuvant PD-1 blockade with dendritic cell vaccination. This is a group of 20 patients in each arm. And then the endpoint, this was a window of study, window of opportunity study. So the endpoint was really to look at the tumor tissue after the neoadjuvant blockade, and then also look at overall survival in the group that got DC vaccination plus PD-1 blockade versus the group that got DC vaccination plus placebo. This study is still ongoing, so I don't have the results of this study yet. We actually, after all the preclinical studies and IND enabling studies, we got FDA approval in November 2019. The trial opened in 2020, but had some fits and starts because of COVID, but we've already enrolled 20 patients. We're halfway through, so anticipate we should have the results of that study, in the next year or two. But one thing that was interesting, in some of these patients was that just like we saw in our animal studies, we saw an enhanced immune response with autologous tumor lysate and the anti-PD-1 antibody. But we saw this very profound immune response in some of these patients, very similar to like the side effects that you see in people who have gotten, CAR T therapies. So, this is an example of one particular patient. He got the autologous tumor lysate dendritic cell vaccine plus Pembro. As part of the trial, at the window of opportunity trial, we did surgery, took out his tumor. He clinically did better. We were measuring CRP and other kind of, immune or inflammatory markers that actually went down. And then subsequently, he had injections of his subsequent injections. And every time he had an injection, these markers went up to a point where in this particular case, he was getting so much inflammation that we had to treat him with an IL-6 inhibitor, tocilizumab, and then eventually we were able to control the inflammation with Bevacizumab. But in this particular study, this is actually a patient where his post Pembro plus vaccine treatment caused so much inflammation, we had to go back in and resect some of the tumor tissue. And what we found was actually quite interesting. So following just neoadjuvant PD-1 inhibition, we saw increased T cells. This is a CD3 T cell marker. The red dots are T cells. But then when when he had the vaccinations with the pembrolizumab, he had increased T cells. And this is probably what led to some of that inflammation that he had that required subsequent debulking of the tumor. So, but this actually probably was not the reason he had so much inflammation. It was probably because in addition to the T cells coming in, he had, after immunotherapy, there was a huge migration of immunosuppressive myeloid and macrophage cells. So even though there were the red cells, the T cells getting into this tumor, there were these immunosuppressive cells that came in, and really there's this battle going on in the brain between the tumor cells and the T cells, and then this new population of myeloid cells that were actually induced by the immunotherapy, because we don't actually see this as much in people who didn't get the neoadjuvant PD-1 inhibition. So, so this is kind of, what it looked like. So this was the initial surgery where, the patients only got the PD-1 antibody, and there was, some increased, the tumor cells are in blue, the T cells are in red, and then the green cells are the immunosuppressive macrophages. And then after the combination treatment, you could see you do get more of the T cells, which are the red cells, but many, many more of the green cells. So this whole lesion was actually being overcome by these green cells. The green cells, the immunosuppressive macrophages, actually outnumbered even the tumor cells and the T cells. So, and this is, these green cells are fighting the red cells, and over time, it allows the blue cells, the tumor cells, to outgrow this population. So that led to kind of the design of our upcoming clinical trial, because I think it's not going to be enough to just, what we do know is it's not enough to just use a checkpoint inhibitor. You need to get the T cells in. So that's why we combine the activation signal, the vaccine, plus, to get the T cells in, plus the checkpoint inhibitor. But then as a result of that, we get this compensatory or response whereby that combination of immunotherapy creates this huge influx of these myeloid macrophage tumor suppressor or immune suppressive cells. So this next trial is really a combination of dendritic cell vaccine plus poly-ICC to activate that danger signal, that innate immune response, immune checkpoint inhibition to really block the immune checkpoints, and then CSF inhibition, which actually is an agent that blocks those green cells, those myeloid macrophage cells. And that's kind of the upcoming trial design. And this is, the design where we're going to try to add those other components to this current PD-1 plus dendritic cell vaccine trial. One other thing that I think is lacking in the field is the ability to monitor response or to actually have biomarkers to determine which patients will have a response. And one thing that we've been looking at over the years is the I guess the use of TCR, T cell receptor sequencing, and the overlap of TCR sequencing antigens, the antigens for which these T cells are responsive to look at that overlap between the peripheral blood and the tumor. Because if you can imagine, if there is the peripheral blood has antigen-specific T cells that actually can get into the tumor that match the antigens within the tumor, then the hope is that there will be this kind of perpetual replenishing of T cells from the periphery that could get into the tumor and attack the tumor, rather than relying on the intratumoral T cells, which, as we have shown, are for the most part, tired and exhausted, and get even more tired and exhausted when you give PD-1 inhibition. So, so this is, a potential blood marker that we could potentially monitor over time to see if there's any response to immunotherapy. In our prior dendritic cell vaccine trials, what we did find was that people who had a high overlap pre-op and a high overlap post-op, for the most part, they all have very good responses, meaning long-term survivals of more than 5 years or so. In people who had low overlap before treatment, there was a group where they were able to have high overlap after treatment. Some of those had very good responses and some did not, and we're still trying to figure out what dictates the difference between those that respond and those that did not. And then if you don't have any overlap either before or after treatment, for the most part, we're not seeing the T cells expanding that will actually attack the tumor antigens in the tumor, and those tended to have poorer survival. So I'm just going to spend the next few minutes just talking not so much about the science and the immunology, but more so about the clinical trial design. And this is actually the other reason I think we don't have any FDA approved treatments for immunotherapy right now. As I mentioned, there's the science behind it, because there's I think the need to use combination immunotherapies and combinations in the right order and the right rationale for using these treatments, and that's certainly a big part of kind of the bottleneck that we're having in the field. But I think another problem with getting these treatments to patients is really the clinical trial design. And as many of you know, there are challenges to randomized clinical trials, particularly in glioblastoma. It is so hard to get now patients who want to be the placebo arm of any trial, and that becoming more and more difficult for these larger phase 3 trials, because most patients would rather go to a phase 1 or phase 2 trial where they're actually guaranteed the treatment, even though it hasn't shown efficacy in those early phase studies. So patient recruitment and retention is difficult. There is a lack of active treatment. The lack of an active treatment arm in the control arm does, have some ethical issues, as you can imagine, to really keep patients on these trials when that they're only getting the placebo. And glioblastomas are rare. It's a heterogeneous disease compared to other cancers. And the numbers that we need to do these trials are just not there. And then given the heterogeneity and the substratification that, you need to have in order to show efficacy even in small subgroups, that's just incredibly difficult. And not only is there stratification of the tumor, there are also characteristics of the host and the host response that, I didn't really talk about, but, the host it also plays a role in this heterogeneity. And then, as I mentioned, we have the lack of biomarkers for response to a lot of these treatments. And then by the time you finish a trial, there's rapidly progressing new knowledge that could change the course of how you evaluate treatment response, for instance, and a lot of the way we evaluate treatment responses by imaging. And as you know, that has changed over time as well. So there is more of a movement towards the use of external control arms. And this has been done in other fields outside of brain cancer, for other cancers. And I think it is gaining popularity, and it's something that I think our field really needs to consider more deeply, simply because of the problems with, getting good data from randomized controlled trials and keeping patients on these trials. So, and this is just a schematic that was that shows how some of these trials can be designed whereby you use external data with some propensity matching and, get your kind of virtual treatment versus control arms. There's actually some guidelines in terms of, quality checks for what would serve as kind of good data sources for selection of external control arms. And many of these, have to do with, like, for instance, getting data from large, well-controlled randomized clinical trials, because the database and data collection is relatively good in these larger kind of well-controlled trials. You have to look at the similarity of the data sets, synthetic control methods, as well as the relevance and reliability. And I'll touch a little bit about that on that a little bit later. But so with that in mind, I mean, if you just look at the, for instance, the last 7 to 10 years, there have been several large randomized controlled trials that have been done for newly diagnosed glioblastoma, and many of these trials have control arms. So this is the control arm in these studies. So there's, in this particular study, there was 411, 229. If you add all these control patients got the exact same thing. They got radiation and temozolomide, the Stoop protocol. So if you just look at these control patients, you already have 1,300 control patients who got the exact same thing. And if you look at the Kaplan-Meier curves of these trials, they absolutely overlap. So one question is, do we need to do another, do we need to have control arms for all our future clinical trials where we enroll another thousands of patients onto the control arm if we have a robust data set that shows pretty much the same survival among all these patients who got temozolomide and radiation? One thought was that, well, how rigorous is the use of external controls? Would a study that a true randomized control study that was negative be erroneously, statistically tested as, or come out as positive when we use these external control arms? So this was just an exercise that showed, for instance, the CELDEX study with rindapipimab and temozolomide, using that as the experimental arm and testing that against all these external controls. That trial actually turned out to be negative, as similar to what the controlled study showed, as did dose-dense temozolomide. The only trial that actually was positive in this comparison was actually the tumor treating field study, which actually was also positive when the actual randomized controlled trial was done. And then, when we think about randomized controlled trials, as I mentioned, there's the issue about, having patients on the placebo arm, and then the ability to really kind of, rigorously do this in such a heterogeneous population of patients, such as those who have glioblastoma. Another consideration is that, well, are these randomized control arms really reflective of the real world, population, what we do in the real world for our patients? And one thing that I noticed, in the data, from pulling the data from these trials that have been done over the last decade or so, the majority of these patients that were enrolled in these trials, up to 94%, 87% was the average, 87% of these patients were white. So we really are lacking in diversity in our, randomized controlled trials in neuro-oncology in our academic centers. So that's something that I think we really need to think about more deeply. I mean, is one, are randomized controlled trials the best, way to test new therapeutics? Even if it is scientifically, is it the best representation of what we will actually do, clinically for our patients? Because the representation in these trials is really not reflective of what the real world is. At least not in Los Angeles and New York, I think. So in conclusion, things to think about, how to accelerate the translation and clinical development of new glioblastoma therapies. I think we need to develop better immunocompetent animal models that better recapitulate tumor and host heterogeneity because heterogeneity is still a very big problem with the studies that we do in this for this disease. We have to consider timing, sequencing, and the role of surgical resection in combination immunotherapies. And it's not just a matter of throwing everything together at the same time. I think there is, some thought that needs to be put into how the immune system works, how the immune response works, and how to time the combination treatments to best fit that. We need better biomarkers of response, whether it be tumor or blood or CSF biomarkers, and or imaging biomarkers that could actually look at response to treatment or stratify patients that would respond to certain treatments non-invasively. And then, these previously large randomized controlled trials have been done in glioblastoma. It would be good if these trials release their data so that it could be mined for external controlled propensity matching. And also, I think more of a movement towards the use of external control arms for registration on our trials, or even going on to phase 4 trials with real world efficacy, as opposed to having this kind of stepwise progression from very strict randomized controlled trials that could get you publications and FDA approval, but aren't really being used in the real world because they're just either not practical or not reflective of the population that we're serving. So with that being said, I just wanted to end with kind of an overview of our brain cancer SPORE at UCLA. The theme of our overall SPORE is targeting resistance. And what I talked about today was just project 1. It was this project that's led by myself and Rob Prince, where we're looking at immunotherapy resistance and how to target the tumor microenvironment to improve immunotherapy resistance. We also have a project led by Tim Clousey and Dave Nathanson that's looking at resistance to chemotherapy and targeted inhibitors, and how actually by giving targeted inhibitors, it leads to this metabolic vulnerability state, and also but this vulnerability state that could be, I guess, attacked by, for instance, BCLX1 inhibitors. But there are 2 blocks to apoptosis, and the goal really is to block both of these signals when patients are treated with these inhibitors. And then our third project is a study on radiation resistance. This is led by Frank Pachonk and Leah Nymphu. And it's really looking at, why radiation fails. And one thought is that it actually induces this population of glioma stem cells that actually then becomes, non-radiosensitive. And there's some, interesting clinical trials based on preclinical data that we're starting with the use of dopamine receptor antagonists and statins for radiation-resistant tumors. So with that, I just wanted to say thank you for your time, and thank you for inviting me to give this talk. It's really an honor to be here. Hi, Sander.
That was great. A tour de force for sure. I'm so fascinated with the non-randomized clinical trial thing. What does that mean for FDA approval if you went that route?
Well, I don't know. I mean, I think the FDA, hopefully would be more open to this.
Have they been for other cancers, or is there a track record of them allowing for that type of data and giving CMS approval to move forward to develop anything like that?
Yeah, not final approval. I mean, I think there have been some conditional approvals. I think other regulatory agencies are more open to this, the European ones, the Canadian ones. FDA is a little different in the sense that they don't, you know, for those of you who've done, you know, kind of submitted things to the FDA, it's almost like you submit it, and if you don't hear anything for 30 days, it's good, right? So, you know, we submitted things, and, you know, there wasn't a negative response, but I think as far as other treatments, you know, I don't know off the top of my head anything that's had, you know, final approval, but I think we're at a point, at least in glioblastomas, where, you know, I'm not sure how we're going to get anything approved if we have to do big, you know, hundreds of patients randomized trials.
Yeah, I agree.
Hi, Linda. It's Guy. That was great. Thank you.
Hi, Guy.
I had a quick question for you. Maybe I missed this because I had to be back and forth with something else. But in your PD-1 trial that you're running, I saw that it was for, you know, for resectable recurrent tumors, but is there any sort of screen, you know, because obviously there's been a bunch of papers looking at which tumors may be more or less PD-1 sensitive, and so how are you pre-screening to up the ante on potential responders?
Yeah. Right now we're not pre-screening because actually we don't know exactly which biomarkers are, you know, are going to be you know, the potential responders. My personal opinion for immunotherapy in general, I do think the mesenchymal subtype are probably going to be more immunoresponsive, and there've been other groups, you know, Mark Gilbert and Amy Heimberger found that as well, and I think perhaps also the people at the Mayo Clinic. But the problem is, I don't think there's any consensus as how to test for a response, you know, whether it's by imaging, whether it's by immunohistochemistry, sequencing, you know, there's no test yet that we have.
Thank you.
Hi, Linda. This is Fabio. Very nice talk. Good to see you. In this issue of, you know, the PD-1 inhibitor, when given before you have a primed or in a subprimed tumor, do you have any idea when, after, for example, giving the dendritic cell vaccine, this tumor will be primed, that then, you know, will be the best timing to add a PD-1 inhibitor? Yeah,
good question. In our animal studies, it's about 2 weeks, because I mean, I think theoretically you want to get T cells in. So hopefully, I mean, if T cells are going in and they're, you know, and, you know, we could take them out and be sure they're antigen specific. If the T cells are in, then theoretically they should be primed, and it takes, you know, it's probably about, you know, 2 weeks in humans. But you know, we haven't done the study where we go in and biopsy, you know, we haven't taken out the tumor in the human to really know that.
And another question, what do you think is the ideal mice model for studying immunotherapy? Because one of the issues of GL261, for example, it seems like everything works.
Yeah, I think that's one problem with immunotherapy. There's just no good mouse model, right? Because you need an immunocompetent model. I mean, the best kind of models for heterogeneity are the, you know, the xenograft models, but they don't have an immune system. So so I think that's why we rely a lot on these, you know, window of opportunity studies where we actually, you know, just test these agents, you know, in humans and take out the, you know, the tumor, and actually I think we probably need to move that into the newly diagnosed setting, because, you know, a lot of trials now are done in the recurrent setting, but actually I think immune therapy works much better in the newly diagnosed setting before, you know, everybody's kind of failed all other treatments. So I think one of our next board trials is actually to, you know, do the recurrent trial, but, you know, with newly diagnosed patients, but with these window of opportunity types of designs. So for instance, we would give the immunotherapy, before or after radiation and chemotherapy, and then have a, maybe a 12-week set point where we go in and biopsy and see what's going on.
Thank you so much for such a wonderful and comprehensive talk. Just a couple questions. One, curious about your thoughts on CAR T cells and sort of the promises and pitfalls and the failures that we've seen. We know just based, of course, on what you're saying, the activation is important. We seem to obviate the need for that with these activated CARs. It seems like maybe the predominant issue is the myeloid suppressors. I was just curious if you think there's still sort of hope there in that field as an immunotherapy. And then secondly, with respect to the radiation resistance that we seem to be incurring, do you think that there's some possibility that, in the recurrent setting, perhaps for methylated patients, that there's a role for overcoming that with, for example, stereotactic radiosurgery, where we can overcome some of the radio resistance? Is there, any thought at combination therapies with that?
Yeah, great questions. So as far as CAR T therapy, we actually have, one of our developmental projects in our sport is actually a bispecific CAR T. And it actually is, it's basically a CAR T to target the antigen target, but also it releases, something to target TGF-beta. So basically the immunosuppressive signal that occurs when you actually put in adoptive T cells. So I think, I think there are kind of innovative ways to design, CAR T cells that could hopefully, because what you need to do is not just target the tumor cells, you have to fight off the other stuff that comes with targeting the tumor cells. So I think that hopefully, may have some promise. It's still, as you know, it's still not great for solid tumors. It's shown, a lot of, efficacy for blood tumors, but where that will be for solid tumors, I don't know, but I think we need to move beyond just single target CAR Ts if we're going to try to tackle GBM. And then in response to your answer regarding radiation, yes, I think actually, as I was mentioning, what's the third project in our sport is actually from one of our radiation, oncology colleagues, and it's looking at, so what he did, and I didn't get into this, but what he did was he looked at cells that actually were, basically grew out despite radiation, basically were radiation resistant. And if you just look at cells themselves, they should, GBM is pretty radiation sensitive, but then why can't you kill them in the brain? So he basically took those cells and did this kind of screening panel to see what actually prevents these cells from transforming from a radiosensitive cell to a radio-resistant cell. And interestingly, the agents that came up the most often were dopamine antagonists. So actually, we're starting a trial of quetiapine, which is Seroquel for these tumors, and I think there could be a role where, for instance, if you had a glioblastoma patient who got radiation or, and then failed, there could be a role where you actually re-irradiate and then give these kind of agents, like I said, one particular classes are the dopamine antagonists, to block that transition from the the radiation sensitive to the radiation resistant cells. Because interestingly, the use of this drug, like the dopamine antagonist, it doesn't work by itself. You actually have to do it with radiation at the same time, which I think is an interesting phenomenon.
Interesting, thank you. So if that's all the questions, we'll maybe let Dr. Liau take a short break, and then the residents can stay on for their meeting.
Okay, great.
Thanks, Linda. Appreciate it.
Thanks, Sander. Let me know when you want to come to LA.
Thanks very much. Great talk.
Bye-bye.